My name is Ron Gupta, and I'm a current fourth-year medical student at Oakland University William Beaumont School of Medicine. I will be presenting our case of the week titled Supraclavicular AV Malformation. A 34-year-old female with a past medical history of Hashimoto's thyroiditis and hyperlipidemia presents to the ED with left-sided neck pain and numbness of the left upper and lower extremity. The patient reports 1 to 2 episodes of numbness per day for the past year. She endorses left neck pain and swelling. Physical exam demonstrated facial swelling along with diffuse sensory deficits present throughout her left upper and lower extremities. Pain was reproducible upon passive and active movement of the involved extremities. Lastly, a non-palpable pulsatile mass without localized warmth was appreciated. Figure 1A is a coronal CT image of the chest, which demonstrates arterial branches labeled by the white arrow, arising from the thyrocervical trunk feeding an enhancing mass in the left neck, represented by the yellow arrow. Figure 1B is a coronal CT image of the chest, which demonstrates an arterial branch of the left subclavian artery, represented by the white arrow, supplying the enhancing mass. Here is a cinematic video from digital subtraction angiography of the left common carotid artery, demonstrating a lesion with temporal enhancement. On the left, figure 3A shows left subclavian digital subtraction arteriogram, demonstrating arteries arising from the thyrocervical trunk, represented by the white arrow, and from the subclavian artery, represented by the black arrow, supplying an enhancing mass. On the right, figure 3B shows left subclavian digital subtraction arteriogram, demonstrating late enhancement of a mass, represented by the yellow arrow. Our final diagnosis is AV malformation for the following reasons. An AVM is diagnosed based on a large enhancing nidus that is supplied by arterial trunks with a large aneurysmal outflow vein. Imaging findings demonstrate left supraclavicular AVM superficial to the scalenes with arterial supply by 2 dominant vessels. These findings can be seen on CTA and left subclavian arteriogram. The patient's clinical signs and symptoms represent complications of an AV malformation due to its mass effect on the brachial plexus, leading to left-sided facial and arm paresthesia. Our top differential diagnoses are as follows. Subclavian artery aneurysm. A subclavian artery aneurysm would manifest on a CTA or arteriogram as an enhancing round, smooth-walled mass communicating with the subclavian artery without large draining venous structures. In the imaging provided, there is the presence of a large draining venous structure. Paraganglioma. The typical location of a paraganglioma is at the bifurcation of the carotid artery, anterior to the bifurcation, or at the level of the jugular foramen at the base of the skull. Imaging should demonstrate an enhancing mass with delayed washout. However, a feeding vein should not be evident. Brachial plexus neuroma. A brachial plexus neuroma will manifest on CTA as a brightly enhancing rounded mass, without an arterial or venous connection. The imaging provided demonstrates both arterial and venous connections. To conclude, an AVM is an abnormal tangle of blood vessels connecting arteries and veins without an intervening capillary bed. Ultrasound is widely recognized as an initial screening tool for AVMs due to its ability to evaluate for vascularity. However, due to the limited field of view from ultrasound, CTA with contrast is performed, which is able to provide a 3-dimensional reconstruction of the vessels. AVMs are treated symptomatically, which may include pain from the presence or pressure of an AVM, or steal phenomena causing distal tissue ischemia or high-flow congestive heart failure. Definite treatment for an AVM may include surgical intervention to remove the AVM, creating an artificial clot to close the lesion, or focused irradiation treatment, which can help achieve vessel closure. Thank you for your time.